I'm now going to start with introducing, I'm sure who doesn't need any introductions, our case study this evening that you're going to share with us is about managing a deteriorating patient in the operative environment. And I'm sure you all know Siva is one of our general surgeons and has a huge amount of experience and expertise. So we're really looking forward to hearing your case study tonight. So thank you.
Thank you. So what I thought I might do today is get started first.
Yes.
Okay. So I want to draw the attention to the ACT surgical audit of mortality, which we've been doing for a few years now. And, we've had the last year's report was out. There was over 76 patients that had mortalities was analyzed and closed. And as compared to the Australian population, Australian database, we sort of similar group of patients that we dealt with here. So one of the things that we've been accused as surgeons is to operate on patients that we should not be operating on. So this is the opinion of our peers. So these are surgeons commenting about what we've done, and the most common things that the surgeons have said that is our criticism is the decision to operate. So I've had a lot of heated discussions with anesthetists, especially intensivists, about operations that we should or we should not be doing. And what I've tried to do in this presentation is that I'm not here to tell you whether you should operate or not. What I'm trying to do is to present some cases that highlight some of the issues that we've faced as clinicians. At the end of the day, we want to do what's best for the patients, and we've heard something very powerful today about Mark. So what I'm trying to do is to raise some issues that we hopefully will, by the end of the evening, will get answers to. So as rest of Australia, we can see that most of the patients that we deal with or who die in ACT are emergency patients, and that's consistent with throughout the Australian population. So most difficult decisions are with emergency patients, which we'll talk about. And again, if you look at all the recommendations Australia-wide, one of the common things are delay in definitive treatment and decision to operate and the type of operations that's been done. So really surgical futility is what it means is to define what a successful outcome is. So we all need to be talking the same language. What are we talking about when you're talking about outcomes? And we want to know what's the level of certainty under uncertain circumstances that outcome is going to be achieved. So that's what surgical futility is. So the problem with measuring that is that it's really trying to agree on what the goals of therapy are, because that's very difficult to interpret. Everyone has a different interpretation what's the ideal goal of therapy is going to be, and really the goals of therapy are really open to interpretation, and sometimes we can have unrealistic expectations. So the patients may have unrealistic expectations, surgeons may have unrealistic expectations. So, and there's a lot of reasons why that may happen. So there's a lot of work done on futility, and there's various types of futility that we need to talk about, like physiological futility, and really quality of life futility is, what are the chances of them able to get back to enjoying their life. So in elective patients, it's a little bit easier in a sense that these are patients that we as surgeons have seen in our rooms. We know them, we know what their goals are. We've discussed all these issues, so we understand their goals of therapy a lot better. So we are able to, if once they deteriorate, we know what we've discussed, and they're easier to manage the goals of therapy. But in emergency patients, it's a lot difficult because we've never seen these patients before. We don't know what their pre-morbid state is. We don't know what their wishes are, because a lot of these patients are quite sick. And we rely on next of kin and family members who often have not thought about these things, and often it's a bit of a shock to them. So they're not able to give us any ideas of what the goals of therapy is going to be. So emergency patients are very difficult, and I found it very difficult to make decisions about emergency patients because I don't know what the goals of therapy is going to be. And as surgeons, we've discussed this during our audit meetings weekly. one of the biggest problems we've often are left out of the end of life discussions because, and it's getting better, but it's one of the biggest criticisms we've had, and that's one of the biggest topics that we've discussed each month when you have these audit meetings. But in elective patients that have deteriorated, we are the best persons to deal with, or at least to be part of this discussion, because we've talked to the patients, we've managed them preoperatively, and we are going to continue to manage them postoperatively, no matter what the outcomes are going to be. And I think as part of end-of-life discussions, surgeons should be part of that discussion, especially in elective patients. So I'm going to start off with some cases. I'm going to make this interactive, so I'm going to point at people and ask them questions. So the first patient is a 71-year-old patient who normally lives independently, had no comorbidities, was recently admitted with pain, and on further investigation was found to have multiple widespread skeletal metastasis. The primary was a prostate cancer and was started on treatment. And the pain was so bad, the patient was admitted to Clare Howland House for pain management. So at that time, they had some advanced care plan drawn up. So it's not for resuscitation in the event of a cardiac or respiratory arrest, but for all acute care for reversible causes. So his pain was reasonably well managed on medications, and he was sent home. And 5 months later, he presented to the emergency department with acute abdominal pain, which on further investigation was found to be due to a perforated duodenal ulcer. So the question that I have is, what do we do in this patient? So who's got a not for resuscitation order, who's got widespread skeletal metastasis, but has a potentially reversible problem. Anyone has any views about what we should do? Sorry? Now, it's got a free perforation, generalized peritonitis. Patient is starting to get sick. So just to cut it short, so we had quite a lot of discussion with the patient and the family, and they want treatment. They said this is a reversible thing, and potentially I've got a chance to get back to where I was a couple of weeks ago. So we had a laparotomy and oversaw of perforation. And post-operatively, the NFR order in the notes, to some extent, and that's where we have a lot of room to move in this space, is that as soon as you see an NFR order, nothing happens. The patient does not get even aggressive medical management, which is not a hard thing to do. So the patient had some fluid boluses, had a med call for drowsiness, had Narcan. He woke up. All his narcotics have been washed out of the system. He was in agony. And really the resuscitation was unknown. So after a lot of negotiation, we said we'll try a short-term, given that he's had the operation and this is potentially reversible. He was admitted to intensive care, but he progressively got multi-organ failure, and then we withdrew treatment and he died straight after. So one of the things that I've raised from this issue is, end of life, even if there's patients not for resuscitation, we need to be clear about what the goals of therapy is. Medical management NFR does not mean no medical management at all. If that's the case, surgery without support, I would definitely not do that. If I'd known there was not going to be any support, then that's not something that you should undertake. So any comments about the first patient? So it's not an uncommon situation. We see this quite a lot of times. And this is the worst thing that I can see in a patient's notes. If I see this with 3 stickers, somebody feels strongly that this patient is not for CPR. If that happens, patient does not get any observations, no fluids, nothing. So it's not uncommon to see that in clinical practice. So I think that's one area we definitely have.
My suggestion would be at that time, I might ask the oncologist involved as to what the normal life expectancy.
So I did speak. So all these patients are my patients. So so I did speak to the oncologist, and they said with bony mets, again, these are all open to interpretation. He said you could live for a couple of years more, 2 or 3 years. so that was what that's the person I spoke to before I spoke to intensive care to try and negotiate some short trial of intensive medical therapy.
Siva, excuse me. Were you going to make a comment? Or?
Yeah, it's Michael Chapman, senior palliative care specialist.
Sure.
And
Sorry, Michael. Anyway.
yeah, thank you so much for bringing up the case. It raises some really, really important points. And I guess I really just wanted to agree with you on several of the points you made, particularly around the potential appropriateness of a person getting an acute or surgical intervention for a palliative need, which I absolutely support. And also this sense that of recognising that because there's some ceiling and escalation of care, that doesn't necessarily mean that there might not be all sorts of other things that may be appropriate up to that point to try and meet the needs of the patient. Likewise, the palliative care service is often involved in providing and supporting very acute care needs within the hospital for people who are still facing a life-limiting illness. So I completely agree with you.
Thank you for that. So we come to the next patient. So it's an 84-year-old patient now, quite significant medical comorbidities, congestive cardiac failure, pulmonary fibrosis, so all of those things. So it's really quite not the best patient with significant medical comorbidities. Was admitted with a small bowel obstruction. Initially tried non-operative management with some just keeping her fasted and giving her time for the bowels to work. During that time, she developed a non-STEMI, so ischemic cardiac event. And the discussions about goals of therapy and the risks of surgery were discussed. And so I didn't particularly use this for this particular patient, but I used this American College of Surgeons risk calculator. And if you look at the risk of death is around 38% or 40%. So, and all those things are quite bad in terms of risk calculator. So the question here for this patient is that would you offer an operation on somebody who's 84, who's got a bowel obstruction? Without an operation, she will die. With an operation, she's got a 40% chance of death. Lot of no's. So again, we discussed this with the patient, and she said, "No, I want surgery. I know the risks, and I want to go ahead with it." So she had a laparotomy, and while having the laparotomy, she had a VT requiring CPR and cardioversion. The surgery was terminated. The abdomen was left open, and she was sent to ICU. That's when she went to ICU for palliation. But she woke up, and she said, I want to go back and have my thing closed. So we went back and, so this is the part that I was involved with. I was not involved in the first part of this discussion. So she went back and she had the abdomen closed and she went home. So the question about this patient is, I heard a lot about risk calculators. There's a lot of calculators that are available, the American College of Surgeons calculators, there's lots of other calculators. Now, what's the value of these calculators, and really, what risk is unacceptable? 40%, 60%, 90%. If I said there's a risk of 90% death, is that acceptable or unacceptable compared to no operation and 100% risk of death? So what we are not worried about is the survival, but it's more about them surviving, but being miserable or going to a nursing home, which was the risk in that. If you look at it, there was a 75% chance of them going to a nursing home or a rehab facility. So it's a significant risk, and that's one of the reasons. That's one of the things that really worries me about operating on sick patients or elderly patients, is that they survive, but they've got such a poor quality of life. So the third patient is somebody that happened recently. Is a patient with quite severe chronic airways disease, well known to the respiratory team, with some cavitating lung lesions, which was biopsy. They're not sure whether this is cancer, asbestosis, peripheral vascular disease, alcohol abuse. He came in with acute respiratory, worsening respiratory status with tachypnea, increased work of breathing. Had an advanced care directive in place, not for CPR, not for intubation, not for dialysis. Had a failed BiPAP, and was seen by intensive care. Discussed all these options, and given that she already has had all these advanced care directive in place, was sent to the ward. Because of worsening acidosis, new onset of AF, and increasing lactate level, they thought ischemic bowel is likely. So she went up having a CT scan that showed ischemic bowel. So these were explained to the patient, who now said, I want everything done. I want surgery, I want ventilation, I want CPR, because this is something that's reversible. So ask the same question again. What would you do now in this situation? Would you operate or not in somebody who now has an advanced care directive, and we've taken that at face value? Now he's changed the advanced care directive. Now what are the... So I don't have the answers, but I'm hoping that this will be answered towards the end of the talk. Sorry, yeah?
I just wanted to say that with advanced care planning, that is for someone that no longer has capacity. So
Sure.
I think it's sort of fair enough that they make that decision when they have capacity, that they can change their mind. And
Sure.
when you put an advanced care planning, you're putting it for people to make a decision
Sure.
when you can't make a decision. And,
Can
it's
everybody
fair
hear
enough
you?
that they can say that.
Yeah, so yeah, appreciate that. So just to repeat, I think there's recording or something like that. So just to repeat that advanced care directive is patients who cannot make decisions
That's right.
themselves.
So when they've lost capacity and they're giving instructions to someone else to make decisions on their behalf.
Okay.
So the fact that they've thought about that is a really good thing, but if then they then change their mind, I think that's relatively acceptable at that stage with what they want, but then possibly it leads to further discussion with the surgeons
Sure.
as well.
So would anyone operate on this in this situation? Sorry? You would, Phil? So I thought, so my view about this was the patient was quite unwell. I didn't think the operation would be in his best interest. Rightly or wrongly, I didn't operate, and basically the patient died the same day, because he just looked too sick for me to.
Basically, you haven't got enough information, because some of these people have just got a little short segment of ischemia, and you're looking at a very small.
Just for the benefit colleagues at the back, thank you very much.
So to make that decision, you don't actually have enough information, because some of these people are slipping about, particularly when it's embolic and fibrillation, it might just be a very small
Sure.
segment, and you're doing a very minor procedure.
So just to make this, I didn't want to make it a long discussion. I didn't want to make this I didn't give too much detail, because I'm just trying to highlight some issues rather than try and see what's right for this. Yes, this patient, the entire right colon was dead, so he could have ended up with just a right hemicolectomy. But I still felt that the risk was too high, and that's why I didn't. So in effect, that's the decision that was made. So we will hopefully talk about this in the next section. So I won't talk about it. So the third patient is so this is the patient. We've had a lengthy discussion in our audit meeting. I was criticized quite heavily for this, so I thought I'll present that as well. So this is a 60-year-old patient with significant medical comorbidities again. With insulin-dependent diabetes, had a end-stage renal failure, had kidney and pancreas transplant, AF, hypertension, lymphoma. She's a nursing home resident. She lives in the nursing. She's been in the nursing home for 4 years, but she walks around, and the sister said she has a the patient was content, had a reasonable quality of life, even though she was unwell. Because she's been suffering this for many, many years, she's learned to live with these comorbidities, and therefore she was, that's the situation she was in. So she was admitted on the renal team with DKA, with worse multi-organ failure, and needed to be on renal dialysis. Was on maximal inotropic support. Had a CT scan that showed an infarcted and emphysematous transplanted pancreas and partial infarct of the kidney. So we had a multidisciplinary discussion with the renal physician, the intensivist, this anesthetist, and myself. We also spoke to the sister, who's the next of kin, who at this stage the patient was not able to make her own decision, and the sister said, she would have wanted this done. even though she's a nursing home, she's got significant medical comorbidities, she had a reasonable quality of life that she, so that's, again, just from a time perspective, the reason I was criticized was I operated on this patient. And I resected the transplanted pancreas, but she continued to deteriorate, and then we decided to pull out, and she died straight after. So really, interpretation of quality of life, and one of the things that I've heard is that multidisciplinary discussion is a protection against futile surgery. So in this particular case, my registrar advised me not to operate, Krish, but all the other specialists said operate. So again, there you go. So the last patient is a 63-year-old patient who's reasonably well, admitted with ischemic bowel. We initially did a laparotomy and a right hemicolectomy. We went back the next day, resected some more bowel. So we did 4 laparotomies, and at the end of that, she ended up with just 110 centimeters of small bowel. He seemed to be really struggling, had ARDS, was intubated and ventilated, and became acutely unwell on day 7, where he became septic, very high inotropic requirements, and had a discussion with the family and said, really, the prognosis is very poor now, unlikely to have any good quality of life with the amount of bowel that's left, and we should stop. The family, however, was quite adamant that it doesn't matter whether he's TPN dependent, he needs to have the operation. So after much discussion, we ended up operating on this patient, and we had a bleed, which we again went back and did control the bleeding, and finally he was discharged home and we've since reversed his ileostomy with a good quality of life. So really, it's about prediction of quality of life. So one of the reasons why I want to present this case is that we don't know the answers. We have no way of predicting what's going to happen. But my view is that we got to give the patients the benefit of the doubt within the information that we've got. So really, just to summarize my take on this, having dealing with patients with upper GI cancers, which are generally poor prognosis, dealing with high-risk patients who've had really had struggled post-operatively. Really, goals of therapy is important, and we need to discuss it pre-operatively. We need to discuss it in the rooms, when the surgeons see these patients, see them in the rooms, discuss these goals of care, and be aware that what the goals of care is going to be when the patient deteriorates. And that's the reason why we need to be part of this end-of-life discussion that happens when the patient deteriorates. The other thing is that failure to rescue rates are important as well, and if things go wrong, we need to be able to rescue these patients. If you operate on patients and then not rescue them, I think we have not done them any favors, and that's why it comes back to understanding local expertise. The local expertise is, so if we know our failure to rescue rates are poor, then we should not be attempting any high-risk operations, and that's. So really, that comes down to, I was talking to Jane before, is audit, and we need to have the funding, the facilities to have an effective auditing process. We need to audit our outcomes. We need to know, what our rescue rates are and what the long-term outcome of these patients that we operate on, and see whether we are doing them any favors or not. And really, the things that I hopefully will address in the next few speakers is the ethics of saying no, like the second patient that So Phil felt that I should have operated on the patient. So what are the ethics of saying no? Because in effect, I have deprived him of an opportunity that he may have made it through that particular ordeal. The next thing is the legal implications, and then and what happens if there are disputes among the anesthetists and the surgeons about futility of surgery.
Excellent. Fantastic presentation.